Blepharoplasty is essentially like bleph means eyelid, I think in Greek, and plasty means remodeling of anything. So it's essentially removing usually excessive skin that hangs over the eyelids or is just even a small fold there if people don't like it, and also repositioning or reducing some of the fat pads. So they tend to, as we get older, prolapse through the structures that hold it back, and we can get little lumps around the eyelids that sometimes people don't like. Predominantly, most people refer to the upper lids, but there are people around who are aware of both extra skin and or fat pad prolapse of the lower lids. In terms of whether it's cosmetic or functional, look, it's a bit of both, to be quite frank, and definitely functional when it interferes with vision and thoughts, and people are using their brows all day long to lift up their lids, and when they get tired or fatigued, it does hang in their way and give them both a feeling of heaviness as well as a look of heaviness and tiredness. And so it has both a cosmetic and functional slant. When we're addressing patients for blepharoplasty surgery, there are two things we as doctors or surgeons need to keep in mind. One is the medical benefit schedule, which is called MBS for short, and it's what governs whether the patient is eligible for a rebate, and that's a functional disease really. So they have to have a visual field deficit or have some inflammation or irritation from skin on skin rub, sometimes like how people get it in the axilla or underarms or neck or things like that, so it's just irritating. And so that will authenticate an item number rebate. And if you get an item number rebate, then it allows patients to dip into their health fund if they have one. APRA, who is the governing body for all kind of medical, paramedical professionals, has also in mid-2023 mandated a set of rules basically to try and make it a safer space for patients navigating and to try and prevent bad patient outcomes. There was a spate of media happening around mid-2023 when this all happened, and basically we have to assess patients as having being suitable for surgery. They don't want to be Barbie. We need to exclude something called body dysmorphic syndrome. We have to kind of consult with the patient twice, which allows us to talk to them, give them all the information, disseminate information, answer questions, and let them go away, have a cooling off period where they can talk to friends and family, look up the internet, get some advice, read our pamphlets, come back armed with some questions, and then they consider this information and have the opportunity to cancel. And also, we have to do surgery in accredited day surgery, which unfortunately means that the cost has increased. And it was a way of basically making sure you get an accredited surgeon rather than a doctor with an interest in cosmetics who isn't allowed to operate in the private hospital field. Generally, maybe I'm biased, but I think blepharoplasty should be carried out by an oculoplastic surgeon who's an ophthalmologist specifically trained after doing ophthalmology in surgery around the periocular region, and they know maybe the layers of the eyelid, to finatum, and it allows us to assess whether anything extra needs to be done. So sometimes we lift the lids. So blepharoplasty surgery, as we said, is taking some stuff off, but essentially, I've got, if you look at me, hopefully my lower lids are skirting the coloured part of my eye, and the top lid is just slightly hanging over the coloured part of my eye. I've got a little picture here you may or may not be able to see, but that's pretty normal. Yeah. So if the eyelid is instead, slightly low or impinging on the pupil, or even more so, and we want to lift it out of the way, not that high, we don't want to see the white, but that's called a ptosis repair, and that's actually addressing a muscle inside the eyelid and shortening it, and we do that with the patient a week so we can kind of gauge where we want to set the eyelid height. And this is often something I do on not most, but a lot of the patients who are seeking blepharoplasty surgery actually end up having a concurrent ptosis. And occasionally when the brow is too low, which happens as well when we age, it pushes all the skin into a smaller place. And if you just did a blepharoplasty, you sometimes remove it really too much important tissue, and it still looks tired and weird and older. You don't want to lift it too high, it can look like a clown, but a little bit of a brow lift or stabilization accompanied by this is sometimes required. So I think having all of this information on board and assessment by an oculoplastic surgeon is important, and someone armed in all those areas. And also, one thing I would say to patients who are coming in for a consult is don't have your Botox in 2 or 3 months coming up to the consult. Not everyone has it, but it's more and more common these days. And if we don't ask, we don't find out that people do it to settle the wrinkles here, and then they can't lift properly and everything drops and they get, artificial looking skin there, which if we do is too much. And some people do it around the eyelids to lift the brows and make it look like they don't need a blepharoplasty. And if they come in then, we might take too little and then it wears off and they're not happy with the results. So I think that's important to just flag to patients these days.
So is blepharoplasty a major surgery? What does the recovery period look like, and what are the potential risks involved in this kind of surgery?
Yeah, so I mean, I wouldn't say it's a major criteria. I mean, prior to the advent of APRA, people we didn't have a health fund, we could often even do it in the rooms if it's just skin reduction and we're not going deeper to the fat. Now that we so we often do the fat, which is deeper, and that has slightly higher risks if it's
Mm.
had an uncontrolled bleed. But I would say it's day surgery procedure and a local anaesthetic and day surgery facility with a bit of sedation. You go home the same day. You could expect to have some bruising for 1 to 2 weeks. You sort of go through the purple, and then by about 2 weeks, you might be in a brown or yellow phase of bruising. Most swelling goes down as well within this two period, but there is an element of puffiness or thickness in the lids, which can persist for longer. That most people may not know is there, but you as a patient and me as a surgeon can detect. There can be a feeling of numbness in the lashes. The risks of surgery in my hands are rare, but we can potentially overdo surgery. It's pretty rare because I do all my measurements with your eyelids closed and do a pinch test as well. Temporarily after surgery, you can feel a bit dry if it's swollen, you're not blinking properly. We cover people with drops for that. Underdoing is more common because patients look at themselves with their eyes open, of course, and so they can feel that you could have taken more, but it's really important that we protect the eye and leave enough skin that blink is natural and comfortable. And then in terms of getting back to everyday activity, you can work and drive as soon as the sedation's worn off. You might
Mm.
have a purple bruise look to your eyelids, so as long as you're
Mm.
happy to wear that on show. But I would protect yourself from things that might induce an infection, such as swimming pools, or if your job's a plumber or cleaner, even things like heavy lifting to reduce the wound coming apart or
Mm.
dehiscing. And again, no makeup for a couple of weeks after, probably 2 or 3 weeks, just to protect yourself against infection.
So you mentioned that in a lot of cases, people come to you because of cosmetic motivations, but you've mentioned a few cases where there are where this could actually cause functional issues with vision. So, like you mentioned, driving. Are there any other sort of like functional problems that people might experience from drooping upper
Yeah,
eyelids?
so using the brows all day long, they can get headaches towards the evenings, and they
Yeah.
typically will say that it's worse towards the end of the day. I mean, there is a condition where it's very fluctuating. They can get ptosis one day, not the other day, and that's a systemic disorder. We sometimes ask the appropriate questions and need be send them off for blood tests, but most times it's fatigue towards the end of the day or tiredness and the feeling of peripheral hooding or
Mm.
limited peripheral vision, which we
Mm.
can test formally with visual field testing.